Thank you. So good afternoon all. Welcome to the day 2 post-lunch session of DPH Account 2024. Here we are going to discuss about the impact of climate change and human health. As we are actively implementing the national program for climate change and human health, we have the right panelists here to discuss about the adversities and resolutions regarding the climate change and human health. So I request Mr. Koushik Ganguly sir to be on the dais, please. Thank you.
Slide with this.
Yes, sir. Yes.
Thank you everyone at the outset and for giving me this opportunity to present on some of the key concepts of climate change. And I'd like to congratulate the Directorate of Public Health and its team and the honored guests here who have made this event a huge success as usual. And really a privilege to be able to be part of this crowd. So I would quickly run through a presentation that is more like a context setting for the speakers that are going to come after me, more to do with theoretical aspects of how climate change and its and the pathways that through which it impacts health. So if we go to the next slide. So according to IPCC Assessment Report 4, if we look at it's a very broad schema of how climate change pathways work. So we have what we have here. What we have here is there are three different pillars of mediating climate change impact. The preconditions are environmental conditions existing, social conditions, vulnerabilities of the population, social status, their economic status, and social conditions also act as an amplifier for the climatic exposures. So primarily two direct impact sources. One is through extreme weather event, indirect sources, direct exposure. Indirect exposure where climate change transforms our living environment around us, the ecosystem around us, our water, our air, our the flora and fauna around us, how it influences it, and then through that it mediates climatic health-related factors into our system. The third condition is the socioeconomic condition once again. It's a disruptor as well as an enabler in the case of climate change where, suppose say an extreme weather event leading to large-scale migration from one part of a country or a state to another part of the country. So a large-scale migration will invariably lead to inaccess to health and thereby loss of health security for the population. So social economic condition is once again a multiplier and is dependent on the other two factors. Similarly, health system conditions is an amplifier or a mitigating factor for impact. So health system conditions, how resilient your health system is and how much time it takes to come back to its normalcy after a shock, after a climatic shock is very important in the context of whether it is able to mitigate the vulnerability or not and thereby creates the health impact in the population. If we look at the assessment report 6 data where it tells us about some of the major burden of disease and how climate may have mediated some of these major disease, we can see cardiovascular disease at the top where globally 1.8 crore annual deaths and 55.8% of it, 58% of it is in Asia. We can see from cancer, more than 1 crore deaths and large part of it is in Asia. So the whole point is that Asia and particularly the South Asia, which is the most densely populated part of Asia, is more vulnerable to different disease conditions and the different most salient disease conditions that are likely to be impacted by climate change and we will in future produce more burden for our health system is sort of indicative from this list. So major sources of impact are vector-borne diseases. If we take communicable diseases, vector-borne diseases, waterborne diseases, and foodborne diseases, according to the AR6 report documentation, we see there significant connection between temperature variance and precipitation with proliferation and reproduction rates of vectors. And we also see its propagation to higher altitudes and higher latitudes. It's quite proven. With respect to waterborne diseases, the evidence is very robust in terms of its variance with respect to high temperature, high precipitation, very low confidence with respect to drought or dry conditions. But it is to be noted that for areas with low capacity of wash, waterborne diseases are seen to be having significant impact. Similar for foodborne diseases, there is a strong association between foodborne diseases and high air and water temperature, which helps the pathogens that particularly transmit through food sources to propagate. And the most common pathogens we can see are enteric viruses, Campylobacter, and other things, which have low infective doses, significant tolerance for temperature, and significant persistence in our environment. With respect to CVDs, one aspect is we know, and in the last 2 years, with the increased focus of the national government and also the state government on heat waves, we know that heat plays a significant role in enhancing the risk of cardiovascular episodes in the population. But apart from that, air pollution, particularly where air pollution gets trapped within the lower atmosphere because of atmospheric conditions, cold conditions, can also precipitate cardiovascular conditions, and other pollutants like oxides of sulfur, ozone, and other also can precipitate cardiovascular episodes. Same for one of the major sources of non-communicable disease increase due to climate change is respiratory illness. Globally, around 10.6 of all global deaths are contributed by respiratory illness, out of which, and these are the major causes that climate change can perhaps have a catalytic role in enhancing the burden of disease. So these are air pollutants, PM 2.5, smoke exposure, and increased ambient heat driving impaired lung function. So with respect to cancer, one of the major, although we have listed out a lot of points, the major cause and the major pathway how climate change can cause cancer is by propagation of carcinogens from one location to another location. It can happen very commonly. It may have been observed in many situations where flood waters have carried industrial waste from one part of the city or town or state to another part, and thereby infecting or propagating the carcinogens in other populations as well, is one of the major issues that we see. Moreover, ultraviolet light exposure, precipitation and air condition are also intrinsically related to ultraviolet light exposure, which can also cause melanoma of the skin. Most importantly, I think the third point is very important when we are from a public health point of view, where we are managing water resources, regularly testing water samples. Cyanobacter blooms are sources of toxins that can cause carcinogens. 2 minutes, okay. I'll just finish. So, heat and cold temperatures related mortality, I think we have already covered that. Injuries due to extreme weather event, PTSD, trauma are most relevant burdens of episodes of climate change. Incidentally, this assessment report 6 also talks about impact on maternal, newborn and fetal health. And it is, the evidence is very robust that heat stress and extreme heat can precipitate preterm, increase the number of preterm deliveries, cause low birth weight babies to be delivered, and also cause neonatal distress, which are one of the key issues that we work on in the state. Similarly, malnutrition. So some of the important policy implications, some of which we are already working, and the State Directorate of Public Health is already working, are some of the salient policy issues that we can say is energy efficiency. So health sector is not just an adaptation sector, but also a significantly contributing sector to climate change through carbon emissions, because many of its services and facilities are hugely dependent on conventional energy sources. So mitigation strategies in health sector, adopting renewable sources, greening technologies, and reducing waste in health service delivery can be some cost-effective ways of mitigation measures. Adaptation strategies, I think a lot has been talked about, and nothing new there. We need a very good surveillance mechanism in that. First of all, we need to identify vulnerable populations and the disease conditions that are going to be of priority for us going forward in the next 10-15 years with respect to climate change, and have very good surveillance and information mechanism by which programming can be informed in advance. We need good early warning systems and emergency risk communication that reaches up to the last mile of the community, so that the community is aware of the risks of climate change and health. So these are some of the few things that I would like to leave you with as some things that are already in motion, but we need to improve a lot, and significant food for thought for the state leadership. Thank you so much.
Thank you, sir, for our thoughtful presentation on the adversities and the resolutions. Just let's move on to Dr. Ramesh Dhiman. Sir, are you here?
Yeah, may I start?
Yes, please, sir. Please go ahead, sir.
Yeah, thank you very much. At the outset, I thank the Directorate of Public Health for giving me opportunity for presenting my work on climate change, and I appreciate your effort that climate change you have mentioned at the special session. First slide, please. I think first slide. Yeah, okay, now you can move to next. Next, please. Yeah, just to highlight that what is the impact of, what is the intricacies of the climate change, we expect that by 2100, 4-degree rise in the temperature is expected, and erratic rainfall means sometimes excess rainfall, sometimes drought, and sea level rise up to 0.59 meter is expected by the year 2100. This is the latest estimates by IPCC 2018, and here 1.5 degree rise between 2030 to 2052. So this is the impact. This is at global level. When we compare it at the local level, so this rise in temperature is quite high. We had set up some field units, and we found that 3 to 4 degree rise in a particular month as compared to previous months. This much rise is there. Next, please. Yeah, if you have a look at the vector-borne disease map, the distribution map itself indicates that the distribution is either limited by the climatic conditions or some ecological condition, and comes then sociological conditions. So like say for example malaria. Why malaria is very much concentrated in northeast and Jharkhand, Odisha? This is because of the most suitable climatic condition, and western part of the country is having less suitability because all the months are not suitable for transmission. Say for Kalajar, Leishmaniasis, it is confined to only eastern part of the country. It means the climatic conditions and some geographic conditions are suitable only for this region. And same way we can apply. Now dengue is the threat which wherein climatic point of view, almost whole of the country is suitable for wide distribution. And there are some neglected diseases like KFD, scurf typhus, CCHF, Chandipura virus. These diseases which are not included in the program, they are emerging. So this is a big problem for the public health. Next, please. Yeah, like KFD. KFD, it was confined to Shimoga district in Karnataka. So now there are reports from Wayanad, from Goa, from parts of Maharashtra, and even Tamil Nadu also. Uttarakhand and Himachal Pradesh used to be free from dengue, but since 2009 there are reports of outbreaks from these states. And CCHF was also confined to say, parts of Gujarat. Now it is also expanding. And scurf typhus, it is found in Himalayan area, it is found in southern India, it is found in desert also. So its distribution is also expanding. Next, please. So in VBDs, vector-borne disease, one thing is common, they are sensitive to climate. Why they are sensitive? Because they are vectors. The insects, mosquitoes, sandflies, ticks, mites, they are cold-blooded creatures. The outside temperature affects their life cycle. The temperature affects the development of pathogen in their body, and that is why wherever the suitability is there, there will be distribution of disease. And if the areas are not suitable climatically, that disease will not be there. And another thing is that the distribution itself you can see from the maps, and it will determine the suitability maps. One thing very important, we say in malaria rainfall is very important, but sometimes rainfall can flush off the existing breeding also. So it depends on the pattern of the rainfall, whether it is continuous, intermittently. If it is continuous, it will wash off the breeding habitat. And if there rains are there after duration of 10 days, so it will complete one cycle of mosquito vector. So this is the impact of rainfall. Another thing which we usually miss, we expect that rainfall and same months we will get the cases. It is not so, because these are vector-borne diseases. The development of vector, development of pathogen in their body, then transmission to human beings, incubation period, all these things takes around 1 to 2 months. So that is why there is always lag period between the happening of most suitable climatic conditions and the occurrence of disease. Next, please. So for vector-borne disease, the importance of threshold is almost there. So in malaria, there are well-defined thresholds, 18 to 32, and rather even 16 is also there for P. vivax, and most suitable humidity should be there within the range of 55 to 80%. For dengue, the range of temperature is slightly lower than malaria, so that is why the suitability for dengue transmission is wider as compared to malaria. Chikungunya, same vectors. So Japanese encephalitis, 20 to 32 degree is the temperature range within which the disease can occur, and same way Kalajar and KFD. Next, please. So this is to show the importance of temperature. Say if the temperature is 20 degree, so the development of parasite in mosquito will be completed in 22 days. If the temperature is 25 degree, it will be completed in 12 to 14 days. And you can see 9 to 10 days also, one cycle can be completed in mosquito. Say in southern India, the temperature is very high. Most of the time it remains more than 24. So that is why in spite of all suitable climatic conditions, the malaria burden is low. So that is the reason of low transmission in southern India, in spite of having all the 12 months suitable for malaria transmission. Next, please. So there was a lacuna. How much rainfall is required for causing outbreaks? This quantification of rainfall was not there. So we determined some rainfall at different sites, around 12 to 14 sites. We analyzed the data of malaria as well as the rainfall, and we developed some algorithm, and I will show in the next slide, please. So these are the thresholds, like say months. So in Rajasthan, if the rainfall is more than 77 millimeter in a particular month, then it may cause outbreak after a lag of 2 to 3 months. You can see in some areas, like in humid areas, more than 350 millimeter rainfall at that particular threshold of transmission month is required. So this way we can identify. So such type of work is required for almost, I say, at all the district level, so that we can understand the significance of rainfall in giving early warning for outbreaks of malaria. Next, please. So based on these, say, theoretical thresholds of temperature, rainfall or humidity, we have developed what is the future scenario of malaria in our country. We have been talking about climate change. So just I wish to clarify, climate change means changes in the climatic conditions over a period of longer time. It is not 5 years, 10 years, 30 years or more. So there are climate models based on which we know the baseline temperature, that is also average of 30 years. Then what will be the future scenario? Because we have the projected scenarios that temperature is going to rise by say 4 degree by 2100. So based on this available information, we have developed some projection maps. Next, please. This work was published in 2011, and here very clearly you can see that this area is having red color. It means the transmission window is suitable for 10 to 12 months in this part of it. So the main problem because of climate change in the context of malaria or dengue is Himalayan region, because in this region all the districts are not suitable for transmission. So with the projected rise in temperature, if the temperature rises by 2 to 3 degrees centigrade, so then the transmission can start. So in this way, this information is also available. You can assume like this, say 160 pixels are free from malaria, but in future 155 will be there. It means 5 pixels are having ensuing transmission, means opening of windows of transmission. And here you can see this 5 to 10 to 12 months transmission is increasing, and here also it is decreasing, it is increasing. So district wise information is available. Next please. So with the better developed model by 2030, so they using Codex model of climate, and we published this work in 2019. So this also gives the insight that only the Himalayan region is vulnerable. In northeastern states, the transmission window extends from 9-10 to 11-12 months. Southern India remains unaffected because already high temperature is there, and if the further rise is there in the temperature, so the windows of transmission may be cut. So here we assume Andhra Pradesh, parts of Odisha, they are likely to have reduction in the window of transmission because the temperature is already very high in these areas. Next please. So this information is also available district wise. You can see which month will be opening and what will be the scenario, say 1 to 2 months. So these are the new foci which are opening. These are mainly in Jammu and Kashmir, Himachal Pradesh and Uttarakhand. So I will say again that climate change is going to affect the Himalayan region more as compared to southern India. Next please. So in the same way for dengue also we have projected these scenarios using different climate models, and you can see almost whole of the country is suitable for transmission of dengue. Only northern part, some districts are not suitable there because the temperature remains less than 13 degrees centigrade there. Next please. We tried to see the development of Aedes aegypti, the vector of dengue, chikungunya and Zika. And we have, using the climate models, the projected temperature, say like by 2030, 2050 and 2070. So what will be the future scenario of the availability of Aedes aegypti? So again here the main thing is in Gujarat, Haryana, Punjab and Northeast, we see some changes in the distribution of this vector species. So there will be more flourishing. Say eastern side, which we are expecting low at present, so maybe having high density or distribution of Aedes aegypti. Next please. Kasnur forest disease, you know, it is a problem in southern part of the country. We were not knowing how, why and how it is expanding. What are the requirements of the tick? So based on the biological requirement, ecological requirement and climatic requirements of the tick vector, Haemophilus is the tick, we developed this projected scenario. This is the baseline availability. This is projected scenario which speaks that how far the distribution of tick KFD vector can be there. So you can see this red streak along the coastal area. This is the only suitability area for the distribution of tick. Rest of the area in Maharashtra also, they are not likely to have the distribution of tick, and therefore KFD will not expand much. Next please. So this was based on some models, and now then we developed some on-site changes in climatic condition, whether really climate is changing, what is the impact of vector density, what is the impact on malaria, etc. So we had established some field units in some northeastern part of the country. Next please. Yeah. So in Uttarakhand we set up one unit, and in Assam and even in Mizoram also we set up, and we generated data. Next please. And we found that yes, climate is changing. How it is changing? You say it depends on the study. In all the parts of the country, such studies are not being undertaken. So fortunately, we were having some long, say 20-30 years old data of the Haldwani area, and when we started getting the density of vectors, so we got the density of vector for 7-8 months. Earlier it used to be 3 to 4 months, and the density was too high. It means we call man-hour density, means one person collects 100 mosquitoes 1 hour, and earlier it was 30. So this is the way how temporal and spatial distribution of vectors has increased in Himalayan region of Uttarakhand. Next please. And we got the mosquitoes resting indoors positive for malaria parasite, means antigen of parasite. And the striking feature was in the month of October and November, which are considered cold, because of the outdoor temperature. But since the mosquito rests indoor and usually in muddy houses, the temperature of such houses is more, so transmission continues, and we assume that transmission will not be there because the temperature is cold outside. So this was very interesting finding. That is why sometimes transmission can occur in the month of October or November also in such areas. Next please. And we reported the presence of PV and PF cases from the areas which were not reporting. So this highlights that the malaria is expanding in Himalayan region in the areas which were not having endemicity earlier. So this is because of the changes in climatic condition. Temperature has increased by 2 to 4 degrees centigrade temperature in those particular sites. Next please. So what is the solution? Usually it is asked, so early warning system. So can we have any early warning system for predicting outbreaks? So we have developed these 5-6 tools. So based on rainfall that we found very easy that if we have the threshold of rainfall and we analyze the data of malaria or dengue, we can develop very simple type of early warning system. Another is sea surface temperature and El Nino southern oscillation. Based on the projections of El Nino, we can know the coming months are going to be dry or wet. So it will give us 4 to 6 months ahead of time some information that the coming area is going to be having high rains or dry. So in such areas like Rajasthan, if the rains are going to come, so we can assume that outbreaks are likely to come. Next please. So what is the impact of all these studies, all these findings? So there are some short-term and long-term measures which we can do. So in short-term, IC activity is the only tool in those areas where transmission is not existing. And the areas where transmission is already there, in those areas we have to analyze what is the timing of indoor residual spray for control of vector. If there is extension in the window of transmission, it expands from 8 to 10 months or 10 to 12, then the timing of spray will increase accordingly. Maybe 2 rounds of spray will not be sufficient for controlling the vector. So this is the one thing, and number of rounds may also affect. So this is the only thing in the areas which are already having transmission of the disease. And the intervention we all know and we are doing efficiently. And capacity building of the health staff, particularly in those areas which are not having the presence of that disease, because they are not aware of about the diagnosis, about the breeding of vector, how to prevent themselves from the bite of mosquito vectors, etc. And we have seen adaptive capacity of the community. Say climate vulnerability is one thing, but if the community is rich, like in Punjab, so they can take care of their problems on their own. They don't depend on the health system to help them. They will go to dispensaries. They spray the cattle sheds also. So such type of capacity of the community can evade the presence of disease in those areas. So capacity building, we say if there are poor persons in those areas, so the vulnerability will be more. And like in Western Ghat, we have seen the adaptive capacity is quite good. So in spite of all vulnerability, Western Ghat is having less incidence of disease. Then long term is development of say suitable health system. Fortunately, nowadays we have national program for climate change and human health, and they are training all the state nodal officers. They are training state district officers, and IC material is being developed that is being disseminated. So Government of India is doing wonderful work for as long term measures for mitigating the impacts of climate change.
Sir,
Next, please.
Just to remind you that we have 2 more minutes to complete our session, sir.
Yeah, I will
Thank you, sir.
complete in
Please.
2 minutes. So just to highlight that how the prevalence of diseases is increasing, just to show you. Next, please. Next, please. When we started working in this field, there were only 25,000 cases of dengue that time, maybe 20, 30 years back. But now dengue cases are more in the country than malaria. So there are more than 2,500 or around 3 lakhs cases are there. The cases of malaria are less in the country now. So this is the way how dengue is increasing. Next, please. Next, please. Yeah, chikungunya also is increasing the same way. And this is just to highlight the importance of scrub typhus. You said there is sharp rise after 2010. Next. And year-wise, if say after a lapse of 5 years, if you generate maps, you can find out that the new foci are appearing year by year. So that is very significant. So at local level, the public health system should be aware that these are the diseases which are possibly prevalent there and they are expanding. So they should have real information about the say diagnosis. They should have the tools for diagnosis also and preventive measures. Next, please. So these are some areas we have analyzed where the high incidence of script typhus will be there. Say scurvy habitats, number one, and then humid, warm, humid climatic conditions. Say 14 to 21 degrees centigrade is suitable for the transmission of this script typhus. Next, please. There is one study from southern India, Vellore. So temperature is already very high. So this is very significant finding. If there is 1 degree rise in the temperature, the cases of script typhus will be reduced. So there is the same for malaria. So malaria is not increasing at all because of climate change. It may reduce. So script typhus they have identified that it will reduce if there is further rise in temperature. But humidity and rainfall are helping in the transmission of script typhus. Otherwise, temperature will reduce. Next, please. So now if we see the distribution of script typhus, it is expanding almost all the states. Now we have script typhus except some portion of central India. Next, please. Next. So this is the ecology. So in Crimean Congo hemorrhagic fever also, this disease is also expanding. So there is a lot of more research is required at closer level. So district level information is required. So this is the map generated showing the habitats of the tick suitability, and you see these areas are having more suitability for the tick of causing CCHF. Next, please. So recently there was say we have reports of Chandipura virus from August. This disease was confined to only some parts of Maharashtra, but now it is expanding. It has expanded to Andhra Pradesh, Gujarat, Rajasthan. The sandfly is the vector. So nobody was aware why this has increased. Except sandfly, there is no other known vector of the disease, but lot of mortality was there, and even acute encephalitis syndrome is also there, just like say JE. So this is the threat. So we do not have any information about the spread of Chandipura virus. The only thing is if the areas are not being sprayed under IRS for malaria, so sandfly population will increase. So this might have been responsible for the lack of IRS in those areas. So it needs to be investigated. So this is the overall issue. Next, please. I think it's over. So carry home message is that the spatial and temporal distribution of these, I will say neglected diseases because they are not under program. So this is increasing. So capacity building and knowledge of the communities who are not aware about the symptoms or about the prevention aspects of the disease, it is very much important. One thing is important in public health, if intervention measures we know, like for malaria, dengue, if we implement them properly, so we can negate the impacts of climate change. Some countries are even, they have eliminated malaria. So that is because of the, based on available tools only. So there is no impact of climate change. So we know how to diagnose, we know how to prevent bites from mosquitoes through LLIN or through IRS. We have best combination therapy for malaria. So we should not worry if we are implementing the intervention measures properly. So early warning system, we are very close to, we have identified tools, but just integration is required. So national program is already working on this, and maybe we will have EWS for malaria and dengue in future. Next, please. So these climatic thresholds are required for these neglected diseases at local level, because in one state it may vary from one district to another district. And ecology is also responsible for the, say, endemicity or transmission aspect of the area. So say why Kerala is reporting so many diseases. So that is because of the ecology. It needs to be investigated in details, and one health approach is the only solution. So ICMR has set up one institute in Nagpur for One Health to address all these issues. And now national program is asking to develop health adaptation plan for all the diseases. So this is also in the process. So hopefully we will be having plan in which month what is to be done in which area. So this plan will be helpful in addressing the adverse impacts of climate change. So thank you very much for the opportunity.
Thank you, sir,
Thank you.
for joining remotely. And on behalf of the organizing committee, DPH ICAN, once again, we are thanking you for your brief insight on climate change and vector-borne diseases, sir. So thank you so much again.
Thank
So,
you very much.
We are in the process of, as you all know, we are in the process of solarization of our PHCs. Most of the PHCs are established and all the districts have a solar panel in place. And we are going to have Dr. Nikhil from National Institute of Solar Energy. Welcome, sir.
So, Vanakkam, good afternoon, everyone. It's my great pleasure to be here. Probably I'm on a different axis because I can see a lot of medical terminologies and a lot of medical professionals, but I'm on a different axis talking about technology here on solar aspects. I'm Dr. Nikhil. I represent National Institute of Solar Energy, and we are an autonomous institute of Ministry of New and Renewable Energy, Government of India. And I thank the organizers of this big conference for having me here to share our activities and thoughts, which we are jointly working with NCDC and UNICEF India office for the energy transition in the public healthcare facilities. So I'll give you some of our findings. I'll share with you. It will be very short. I have already given a warning that we should be keep it very short, especially it's a post-lunch session and time is very short. So as I mentioned, we are an autonomous institute under ministry and we deal with all technology aspects of solar. In India, I think we are fast forward on exponential growth, installation of various solar projects, and currently we are at almost 200 gigawatt of renewable energy. Out of that, 89 gigawatt is solar. So probably what you see here is the ground-based solar systems and rooftop-based solar systems. Let me start with a couple of challenges, probably what we have it in everywhere, not just to healthcare facilities. But if you look at any facilities, it is run by energy. And we need energy to run any equipments, basically the electricity. It is a form of electricity. One of the key challenges is that we have to pay for electricity, right? So how many of you pay your electricity bills? Raise your hands. All of you, right? Probably I'm not paying because I already installed a solar. But have you ever thought our electricity bills are increasing? Almost every 5 years it is increasing. Of course, cost is one aspect. Second, if you see the energy statistics, our energy requirement is expected to double every 10 years. That is another key aspect of it. And if you look at the other aspects like the associated emissions, most of the energy or electricity what we consume comes from a source which emits carbon dioxide. So it actually contributes to carbon emissions. So can we become a change on this war for or war against the climate change? I think my fellow speakers already discussed a lot of aspects about the climate change aspects, impacts, but I am here to talk about the resolution or mitigation aspects of it. Another important aspect is that since you mentioned that you are paying your electricity bills, all of you are or become a consumer of electricity. Am I right? All of you are consumer of electricity. But if I say that if you can produce your own electricity, what you consume, then what you actually become is a prosumer. So you are shifting yourself from a consumer category to a prosumer category. Of course, I'm not talking about a production of electricity from a diesel generator, which again can contribute to electricity and is high costly also. But there are more better ways to do that. So solar is one of the good option and solution to that. I will give you a brief about that solution here. Another key challenge is that the second challenge. Before I go to that, do you remember the movie called 3 Idiots? Everyone? There is a Tamil version of that. What is that? It's Namban, right? So if you have seen one of the scenes from that movie in the last, there is a scene where they're taking delivery. There is no power. Suddenly the power goes off. They use a vacuum pump, etc. So is it really possible in a health facility, that kind of a scenario? When I asked my doctor friends, they told, no, this happens only in films. When you need a Sung Wangudu or somebody like that nearby you, then only you can do these things. But otherwise it's very difficult, right? So the power scenario in most of the places, especially in the rural areas, are very critical. There are numbers which indicates that power cuts, like it may be for 1 hour or 2 hours, maybe that 1 hour or 2 hours may be the time where there is emergency critical care is happening and or a delivery might be happening and it can impact the health. So another key challenge is getting a priority backup load for a healthcare facility to meet the emergency demands of the electricity. So these are two different challenges, and to say for these two different challenges, there are two different solutions. So if you look at the technology options in solar, the one is with a battery systems which supports this electrical backup problem. Like if there is a power cuts, they can help in sorting out this. So the primary objective or the priority of this particular system was to meet the backup loads during a critical hours of any emergency happening in the facility, not just to reduce electricity bills. If you want to reduce electricity bills, there are options where there is no battery. You can generate the electricity from a solar. You can easily consume it yourself. You become a prosumer basically, and you can export it to the grid, and you can augment your electricity demands. Thereby, you can reduce the electricity bills in the facility. Then what are the advantages? So by solarization, you get access to a reliable electricity. It's a decentralized technology, like a portable. You be in city or a town or maybe in a village or any place, the technology works where there is a sunlight. So you can take it anywhere. It provides an options for backup. It's a decentralized technology. It can contribute to energy efficiency because mostly you are becoming a prosumer. You are generating your own electricity at the point of consumption. It is a modular options to scale up. If your demand increases, we can easily scale up. That is the best part of it. It of course helps in the saving of CO2 emissions. The impact is that it can improve the quality and quantity. It can bring financial savings. Probably most of the facility managers here or the doctors here know that you get some fund for some activities, and if you can save some fund from the electricity bills, you can use that for other important activities in the facility as well, right? And it can also get improved productivity and well-being of the staff. Most of the interaction which we had in the healthcare facility in our surveys, what doctors was telling that we need some facility to charge our mobile phone. There used to be in the very remote facilities, sometimes there is no power, and they feel sometimes demotivated to come to these facilities because of the lack of power. In this whole scenario, what we envisaged is that in order to put a solar, the first thing is that we need to carry out some kind of a survey to understand what is the actual requirement in a solar, in a healthcare facility. So we carry out a survey, and based on that survey, we propose a design that is carried out by National Institute of Solar Energy and with the support of UNICEF, of course. And this whole design is handed over to the state. Now the state can take a call whether to go ahead with the installations in the solar. And we also take the help of the state energy departments. For example, in Tamil Nadu, it is TEDA, in Kerala, it is ANERT. So every state have different energy departments which can come in picture and support in every healthcare facility in solarizing their facility. So basically, we look at the equipments which are connected in the facility. It could be the basic ventilation facility or a vaccine storage, or could be a diagnostic equipments which are of a critical nature. So already there are some of critical loads which are already defined by the health ministry. So we also look at that perspective. And during our site visit, we look at the electrical equipments connected in the facilities, the space available for putting a solar, what is the kind of a roof, what is the existing scenario of electrical demands in the facility, how the connections are made. Now, based on that, we take a survey based on a mobile application. We have developed a mobile application. So we have a lot of data already available with us. Yep. So based on that, we can design the system, and almost 122 facilities in India, we have gathered the data for different PHCs and CHCs across almost 7 states. We started with UP, Gujarat, Kerala, and a couple northeast states as well. We have seen that at a sub-health center level, the energy consumptions are almost like less than 5 units. At a PHC level, it is near to 50 units. And at a CHC level, it is somewhere near to 150 to 200 units in that range. But district hospital, the scenario is different. Now we look at the action point. Based on this analysis, we have proposed the systems with backup. And this is a specific case from UP. And in UP, we had also done some implementation. Already this is in the field. So our efforts are being converted into actions now. I think last month, almost 70 plus systems in public healthcare facilities in UP have been handed over and installed, and it is still in progress because it's a face-to-face project under the National Program on Climate Change for Human Health of NCDC. And there are a couple of learnings what we have, practical challenges. When we go to the healthcare facilities, data accuracy is one of the important aspects. The kind of data we receive, whether it is actually validating or fitting with the requirements. Many facilities there require a retrofitting with the existing electricity network. The user awareness to solar and other aspects is important. The geographical diversity, because the system what I propose in UP is not what I see in Kerala or maybe in Gujarat or maybe in some other states. The energy consumptions and profiles are totally different based on the geography. Even within the, you can see some PHCs consume more than a urban CHCs. So there are a couple of spots we found that. And of course, the usage of localized resources for comprehensive maintenance, because these systems are to operate for another 20-25 years in the facilities. And there are many stakeholders involved in between state, central, etc. So coordination between them are very, very important. So that is what from my side, we are trying our level best to provide the support to all the stakeholders. And of course, we can also be a part of your efforts to become a solarized healthcare facility so that we can together put hands to mitigate the carbon emissions or the impacts of climate change. Thank you. Thank you once again for having me here. Thanks a lot.
Thank you, Dr. Nikhil, for your wonderful presentation on the energy efficiency and energy conservation measures. Recently, DHO Changalpate has done this job through CSR support. He has solarized most of the PHCs, and hopefully we will all follow this in this near future. So thank you.
Thank you, sir. We request JD Tansak, sir, to felicitate the speakers. We request JD Tansak, sir, to felicitate Mr. Koushik Ganguly, sir. We request JD Tansak, sir, to felicitate Dr. Nikhil Patak Gopi. Thank you, sir.